All right, so hello everyone. Good morning, good afternoon, good evening. Depends on the time zone. Where are you? We all should be in these days in Canada, as a Professor Holger Schoenemann with his team was preparing great conference. However, unfortunately, the COVID-19 situation, we couldn't be there. So we have prepared with our scientific committee another program for you, which is this online pit stop in the COVID-19 marathon. My name is Miloslav Klugar. I am now sitting in Brno, Masaryk University, Czech Republic, and it is my pleasure to welcome you all to the first session of the prepared pit stop, which was developed. Big thank you to Jin. We are able to organize this. Big thank you to colleagues from the scientific committee as well. So, welcome to the session 3, which will be focused on the recommendation mapping. My fellow moderator today is Dr. Markus Follmann, and we have excellent speakers. The first speaker will be Munn from GPI and also from Jin as a vice chair. Then is Falzon from WHO, Tamara Kredo from Cochrane, South Africa, and John Grown from WHO as well. The declaration of interest to start with is Zach Munn. Zach Munn is active member of the Jin, Australia and New Zealand Regional Steering Group at the Jin Tech Group. He's also the director of the GBI Adelaide Grade Center, which was first in Australia. Dennis Falzon is involved in the development of policy using GRADE and have been active in promoting the notion of living guidelines for tuberculosis guidance. Tamara Kredo and John Grow has nothing to declare. For the moderators, my declaration of interest is that I'm involved in several methods group of the GRADE working group, Jin, GBI, and Cochrane, and also director of these centers within the Czech Republic. There are no DOIs for Dr. Markus Follmann. For the welcome, thank you very much for joining us today. I also see by the Zoom familiar names. So I see that most of you attended also the previous sessions, which from my perspective, which might be a little bit biased, were excellent. So we hope that we will keep the standard within this session as well. We would actively encourage you to participate in today's interactive sessions. Your questions and comments can be submitted via the chat box within the Zoom, and the order will be that after every speaker there will be 5 minutes for clarifying questions and answers, so you can submit your questions during the whole presentations. We will also have several post questions for you which we prepared, so we will announce this when will be time for you to actually pay attention to this as well. Today's session will last approximately about 2 hours, and there will be time for discussion at the end for a general discussion. There is also a recording of the sessions which will be available on the Jin website after the conference. Let me to say a few information about the Jin Guidelines International Network. The vision of Jin is trustworthy and accessible guidance for better health. Mission of Jin is to lead, strengthen, and support collaboration and work within the guideline development, adaptation, and implementation community. Jin providing a network and partnership, assisting members in reducing duplication of effort, which was actually also discussed during yesterday's session, and promoting best practice through development of opportunities for learning and building capacity. And right now is a time to give the word to Dr. Markus Follmann, who will introduce our first speaker. So Markus, the word is yours.
Yeah, thank you very much, Miloslav. Yeah, a warm welcome from Berlin. And I'm very happy to introduce the first speaker, which is the Associate Professor Munn. And he's an, he's an advocate for evidence-based healthcare, ensuring patients receive the best care possible based on the best available evidence. And Zach is the director of the Transfer Science Program of the Joanna Briggs Institute and a systematic review and guideline development methodologist. And his role as a GIN Tech Steering Group member and as a product owner of JBI software, Zach is very familiar with the various tools available for systematic review and clinical guideline development and has been involved in the development of these tools. He understands how they can contribute to trustworthy guideline development while still maintaining relevancy and currency, and where their use can optimize the digital and trustworthy evidence ecosystem. So I wonder whether we can get the first slide from Zachary. Yes, please.
Okay, great. Thank you. Thank you for unmuting me, and thank you for that introduction. So good evening, everyone, from Adelaide, Australia. It's a pleasure to be here with you all today and to see some of your happy faces. And thank you, Miloslav and Markus and the Scientific Committee for inviting me to speak today. So today I'm going to be talking about registries, repositories and recommendations, and particularly focusing on the new GIN library, which we've been developing now over the last 12 to 18 months from GIN. And I'd like to walk you through the process of how we have developed this new GIN library, how COVID-19 threw a bit of a spanner in the works, and some of the investigations we did to inform the development of this library as well. And I must say, although I'm presenting today, really a lot of the legwork and most of the inquiries and the studies that I'm going to be discussing today, really it was all led by Dr. Sarah Twaddle, and a huge thanks to her for all her efforts. Okay, so here are a few of my disclosures. Yes, I am from JBI, I'm a director at JBI, but really I'm presenting today as a GIN board trustee and the current vice chair of GIN as well. So these are my disclosures, and once again, a huge thanks to Dr. Sarah Twaddle. So I am from Adelaide, South Australia, so it's getting a little bit late for me now. It's almost 11 o'clock at night here. So once again, I'm very thankful to the moderators for allowing me to speak first. So this is what I'll be quickly touching on today: registries for guidelines and whether or not we need a registry for guidelines. I'll quickly touch on the COVID and recommending group, and then discuss and launch a new GIN library, which some of you who may have been attending the AGM yesterday, I'm sure you would have heard about and are very excited about, just as we are. So Miloslav's already walked through the GIN vision and mission, but it's always useful to put this up at the start, particularly when we're talking about one of the key resources from GIN, which is a GIN library and registry. So our vision is trustworthy and accessible guidance for better health. And our mission is to lead, strengthen and support collaboration in guideline development, adaptation and implementation. And we'll keep coming back to this vision and mission throughout this presentation, because this really has informed the work we've been doing over the last 12 to 18 months and the development of a new GIN library. So let's start off with discussing registries for guidelines, and particularly what are registries. So basically a registry is a place where registers or records are kept. And when we talk about evidence-based healthcare or evidence-based medicine, there are a couple of registries which I'm sure you're all familiar with. We of course have Prospero for systematic reviews, which is very widely used. And we have our trial registries as well, which we of course search for when we're doing our systematic reviews to try to find clinical trials. So when we talk about registries in evidence-based healthcare, and in this context, we're really talking about systems or databases which register trials, studies or reviews, which are they're registered before they're actually performed. So they're registered at the protocol stage or at the title stage, or when you're planning to actually do one of these systematic reviews or a study before you actually undertake it. And when we talk about registries in this presentation, this is what we're talking about here. We're talking about registries where you prospectively register a study or some work which you are planning to do. And the reason these registries are useful is obviously they help identify work in progress, which might be forthcoming or in development, or it may also, if you look at past entries in the registry, it might also help you identify work that has been completed but has not been published widely or has been disseminated widely or is easily accessible. So they can help you find other studies or work that you might be interested in. In terms of clinical trials particularly, registries can help reduce the chance of publication bias when you're doing a systematic review, because you're making sure that you do uncover the whole body of literature regarding a particular question. And of course, it can help us identify selective reporting as well, and whether or not all of the outcomes reported in a protocol, a trial protocol, are actually reported in the final publication. And of course, they can also help reduce duplication of effort and as such, avoid research waste also. And this is particularly true for systematic reviews where, and we know that there are a lot of systematic reviews addressing the same question. And although sometimes replication of systematic reviews is a good thing, in many cases, this is just duplication of effort that we don't need or want. So the big question we had is on the GIN board and the GIN library and website task force was, well, do we need a register for guidelines? And are there any registries for guidelines that currently exist? So what we did is we've done a bit of work over the last year or so to try to find out, well, are there any current guideline registries? And if so, are any of them the ideal registry that we should be using? We also conducted some focus groups with GIN members to get their thoughts on registries and also to help inform the development of the new GIN library, which was launched yesterday. We've had a lot of discussions about this amongst the GIN board regarding how we move forward with our library, and I'll touch on some of those decisions that we had to make. And we've also formed a dedicated task force to look into this as well. We've had a lot of discussions and worked on this. So let's get back to that question. Do we need a register or registry for guidelines? So let's look at the reasons that I mentioned before for the registries for systematic reviews and clinical trials. So one of the reasons, of course, was to reduce the chance of publication bias and selective reporting. And you could probably make an argument that this is relevant for guidelines as well, but perhaps it's not so clear cut. The next reason why we have registries is to reduce duplication of effort and avoid research waste. And I think this is obviously a very good reason why we might have a registry for guidelines. Yes, you may still need different guidelines addressing the same question in different jurisdictions and in different contexts. But if we know of other guidelines that are going on, we could at least collaborate and perhaps work together to avoid duplicate effort. And the other reason, of course, as well, to help identify work in progress or forthcoming, or work that hasn't been published widely or easily accessible, this would be very, very useful in guideline development as well. But one thing we wanted to do as well is try to think of other reasons for why we might want to have a registry for guidelines. So we've had a lot of discussions internally at GIN and with key stakeholders. And one of the main reasons that kept coming up over and over again was to enable collaboration and sharing. And by identifying when groups are working on guidelines early on in the process, they may be able to link up and share their work. And this could be a huge benefit in a registry for guidelines. Another reason why it might be really useful is that you can keep others informed of recommendations on similar topics, and particularly in similar jurisdictions. And in this way, if groups in similar contexts and addressing similar populations or the same population if they know of other groups who are creating recommendations where there might be some crossover in topics and crossover in recommendations, then these groups will know about this work, and this might help reduce the chance of conflicting advice or conflicting recommendations as well. It can also help promote transparency in guideline development also, so that we can see how guidelines are being planned and when they should be and how they should be conducted. It can also help guideline developers raise awareness and perhaps assist in dissemination of those guidelines. And it could also help with identification of external reviewers or peer reviewers for those guidelines as well, or interested parties. So, so it seems like, at least to us, that a registry for guidelines would be incredibly useful for all of these reasons and really align with the GIN vision and mission as well. So we also wanted to find out, well, are there any registries that currently exist? And from a scoping activity that was performed, which is led by Sarah, we actually found 5 guideline registries. The Australian NHMRC Clinical Practice Guidelines in Development Registry, the AWMF Registry, the International Practice Guideline Registry or Register Platform, and a registry from Ukraine as well. And of course, we actually do have a feature in the original or the old GIN library where you could actually specify that your guideline was in development as well, which would serve some of these purposes of a registry. We also found that some guideline development organisations and societies do highlight guidelines in development on their websites, but this is only about 25% of these groups who actually do highlight what guidelines they are planning to do or what guidelines are currently in development. So still a huge gap here. And from the focus groups that were run, we found out that there was actually quite a strong interest amongst all of the participants that a registry would be a really good thing. And the potential for collaboration and sharing and working together being the largest benefit of such a registry, and the main reason why GIN should invest in this. And as I mentioned earlier as well, it could lead to reconciliation of recommendations from different developers. However, it was also recognised by the focus groups and also internally at GIN that if we are going to have a registry, that for it to be useful, we need people to actually use it. And the more people who use it, obviously, the more useful it will be. So the feeling is that if we are going to create this registry, then we should really launch this and widely promote it, and also prompt people to use it as well. And one participant in these focus groups even said that we should instill a sense of responsibility to get things included on the registry, so that every guideline developer and every guideline development organisation should feel a moral responsibility to make sure they do register their guideline. So from the work that we looked at for registries, we found that there really are only a few registries that do exist. None have comprehensive coverage across countries and languages, and that there really is still a gap in terms of registries for guidelines. In terms of trying to actually identify guidelines that are currently in development or being planned, it is actually very difficult at this stage to do this and very time consuming. And the other feedback that we got from our focus groups is that if we are going to really set up a registry and invest a lot in this, is that we need to make it simple and easy for people to actually upload or to get guidelines in development into the registry as well, so that we're not placing too much of a burden on our guideline developers. So the conclusion really was that we do need this a GIN registry that is comprehensive. It's a single source for searching for guidelines in development or guidelines that are being planned. It's easy to upload to, and it does contain all the key data fields that we need, and is open to everyone. So anyone who is doing a guideline will be able to register the guideline in this registry. Now, whilst we were doing all of this work, of course, we were faced with the challenges that COVID-19 has presented. And I'm sure many of you have heard about the great work of the COVID End network. And within the COVID End group, there is a subgroup or subcommittee called the Recommending Group, who are also very interested in this idea of registries for guidelines or guidance, and also repositories for guidance as well, so that we have, yes, a registry of guidelines in development, but also a repository of completed guidelines and recommendations. And I just wanted to show the terms of reference for the COVID and Recommending Group, and the fact there is a little bit of crossover between what we're trying to achieve with the new registry and library and what COVID End are trying to achieve. And we are working closely with COVID End on this. So that brings me now to the new GIN library and the new registry, which was launched with a bit of fanfare yesterday. So this library, it was established in 2003 to allow GIN members to share their guidelines with others. And in the past, largely it was used for sharing completed guidelines, and there weren't a lot of people who actually registered guidelines in development or planned guidelines, which is something we obviously want to change with the new version. When we did our focus groups and tried to collect some information on the current GIN library, everyone said that it was a really good idea and had a lot of potential, but the current library, there are a few issues. The search function could be improved. There are a few broken links, and a lot of the materials were out of date. And some quotes from some of the focus groups are that, yes, people do see these inventories of guidelines very useful, that if we are going to have this library, it should be open to all and up to date. That GIN should stick to the basics and get it right. And there was also a thought that we shouldn't go down the path of actually accrediting guidelines or even necessarily appraising or trying to establish the trustworthiness of these guidelines, but rather that GIN, as the International Network for Guideline Developers and Guideline Development Organisations, that we should approach this with an inclusive mindset. So this left us with a number of decisions and regarding, well, what should we do with a new library? And sometimes we had to debate going down various paths. Do we have a comprehensive library, or do we try to limit it to the highest quality guidelines? And this is still a debate that we keep having. At the moment, we, as I mentioned, we don't have this trustworthiness assessment. At the moment, in the original GIN library, you could fill out a standards form based on a form based on the GIN standards, which was done by those who were submitting the guideline. There was no external review. It was self-accredited, so to speak. And obviously, if we are going to look at establishing trustworthiness, well, how would we manage these resources as well? So we've had a few difficult decisions we needed to make. Also, what fields we should include, and whether we are taking an inclusive approach or an exclusive approach. So who is eligible to submit guidelines? And at this stage, anyone is able to register their guidelines that are being planned or in development. And also, anyone is able to submit their guidelines to the GIN library as well. But for non-GIN members, there is a small fee. And once again, one of the big challenges was, well, how much information do we actually include? And obviously, this leads to a trade-off between a burden being too cumbersome and usability of the library as well. So we wanted to make sure we had all the key items in there so that users of the library would be able to get a lot of benefit from it. But we didn't want to make it too hard for those entering data into the library as well. And really, after the focus group and all of the discussions we've had internally, these were some of the things that there was a lot of consensus on, that we wanted it to be, or we want it to be as comprehensive as possible. We want it to be a single source as much as possible as well, so you can avoid searching multiple sites. It should be up to date. The search function should work very smoothly, and it should be easy to find what you're looking for. That we do need to highlight the registry component as well. And make sure that we really push this hard amongst the network. And it should be easy to upload and submit guidelines. There's also some strong feedback that we should include individual recommendations rather than just guidelines. And this is something that will be touched on in the subsequent presentations. But at this stage, we only include guidelines, not individual recommendations themselves. So I'm very pleased to say that the new registry is now available. The new library is now available. It is free to access, and we've been working with in partnership with EBSCO, who have helped develop this library, and it's been informed by all of this work. You can actually go to the library now at guidelines.ebmportal.com, and you'll be faced, or you'll find a screen that looks like this with the new GIN branding as well. Where you can see here very clearly that you can look for guidelines in development, or that are planned, that are published, or require review. So here we've just filtered by guidelines that are in development, and you can see here also that we've put in things like expected publication date for these guidelines. Here's an example of searching via a key term, searching by COVID. And identifying all the guidelines that come up, which have that key term included. And here's looking at some of the published guidelines, and also looking at the use of some filters as well. And one of the items that we have included in the new guideline is this box about being interested in collaboration or not. So if you are a guideline development group who would really like to work with others, you can now highlight that on your entry to the GIN library. So hopefully we'll start seeing more people collaborate across GIN. So finishing up today, I guess what we've been doing, all of this work has informed the new GIN library, which is now available, which obviously has the registry component. And we are aiming for this library to be as comprehensive as possible to promote collaboration, reduce duplication, and to identify guidelines at all stages of development. At the moment, it doesn't include measures to establish trustworthiness or quality. And at the moment, it doesn't itemize at the recommendation level, but rather guideline level. And this is the first release of this new GIN library, and I would really encourage you all to go in, have a look, to test it as well. And we are really open to feedback and really want to hear what the networks say, so that we can keep making this library as useful as possible for everyone. But that's it for me today, and I'm very happy to take any questions or comments.
Yeah, thank you so much, Zach, for presenting this comprehensive work. And I can imagine that you really had a lot of discussions concerning the direction where to go with the library, and just looking for any comments in the chat. So from Tamara, would you recommend a separate repository for CPG implementation tools?
Yeah, so that's a really good question. This is something we had a bit of debate about within the group as well. In the original GIN library, we certainly did have these implementation tools available to search for as well, and it's something we're still discussing as well. So it'll be interesting to hear what the thoughts are of the network, and whether we should include these again. Obviously, we do link out to the full guidelines and the websites, where hopefully these would be listed and you'd be able to find them quite easily.
Yeah, thank you. Another question from Amir, who's asking if you're not, or excuse me, not yet itemizing at the recommendation level, but could you imagine to install a search function at the recommendation level?
That's a really good suggestion. Thanks, Amir. At the moment, no, I don't think you can search at the recommendation level. It really is at that guideline level.
Okay, and another remark from a question from Sandra Kaplan. It would be great if the library had a portal or instructions for submitting CPGs as well.
Yes, and that's something we're really working hard on at the moment to make it as easy as possible and as clear as possible about how you actually do submit to the library.
Okay, next question is just whether the GIN library is open to the public or restricted to the members.
It's open access, so anyone can access it, not just GIN members.
Okay, and a question from my side, Zach. So if you are talking about one source, that means, because now the new library is working with links as well, which make it easy at the level if you are submitting something that you just send a link and the organization can update their product as well. But if you're speaking about one source, it means that the complete content is getting into one database.
I'm not quite sure if I follow the question, but so what we do is we provide the link outs to the guidelines. We don't store the, I guess, the files themselves within the library. We link out to the guideline page.
Okay. Yeah. So just looking for further questions. It's going fast. What about a public patient view, like layman plain language summary of the included guidelines?
Okay, so that's really interesting as well. Once again, we just link out to the actual guidelines themselves. We don't currently index them in the GIN library, but that's a really good suggestion, which we should discuss further, for sure.
And try to summarize the last comments, and then we have to stop this discussion here. What about the methodological basics? So do you have any check for methodology, whether it's based on systematic reviews or any basic methodological checks or information you are asking?
No, so we don't do any appraisal anymore. And like I said, in the past, people could choose to self-accredit, I guess, or self-check their work with the GIN standards. One thing that we have included as a new item in the library is that you do actually specify what methods you're using for your guideline development, because this might help as well if people are looking to collaborate. If they know that you're using grade methods, for example, that it's going to be easier for two groups to collaborate.
So we have prepared a polling question for you all, and I don't know where we can get there. Do I have to start my video? No, it's Miloslav.
It's been launched, Markus. So
okay, great.
Yes. Thank you very much. So Markus, I think I may have my word back. Thank you. So Zach, thank you also very much for a very important, informing presentation with the important topic. And we have prepared for all our participants the question, which is, shall we have one universal guideline registry? We will see what all our participants think. And numbers are coming, so we will see the results after our next speaker. So our next speaker, it's my pleasure to introduce Dr. Dennis Falzon, who is a medical officer at the World Health Organization Global Tuberculosis Program. He's also the team lead for tuberculosis prevention research and innovation at the WHO Global TB Program, involved in the development of TB policy guidance, monitoring of uptake and disease surveillance, and has an interest in a translation of research to policy, application of digital health to TB prevention and care, advocacy, and technical assistance. Dennis is currently engaged in a drive towards continued expansion of TB services during the pandemic response. So Dennis, the floor is yours. Please share your slides and tell us about your experience.
Hello, can you hear me?
Yes, we can hear you.
Okay, thank you very much, everyone, and greetings. It's great to have this invitation and opportunity to speak to you about this particular subject. So I will try now to share my screen.
Yes, very good. We see your screen.
You see the screen? Okay. Let me see if I. Do you see the big screen or small screen?
Yes, we see the big screen.
You see?
Not
Okay.
now. We've seen it before.
All right. Okay. All right.
Okay. Now it's going back. Okay.
Fine.
We see the screen now. You can go on.
Okay. Thank you very much. So thanks for the introduction as well. So my presentation will cover the experience that we've had recently in planning the recommendation maps for TB prevention and care guidelines. So I'm a full-time worker here at WHO in Geneva with the Global TB Program, and part of my work is to work on policy and development of policy development and guidance, and I've been involved in this notion of living guidelines for TB, and no other interests to declare. So by way of background, we feel that connecting recommendations to the evidence underpinning them is an accessory to the consolidation of living guidelines. That is, guidance that evolves and moves according to the evidence and the practices of the community in TB. And my presentation will outline a little bit the work that we have been doing to improve this process over the last few years. So just by way of introduction, so tuberculosis, which is the subject of the guidance I deal with, remains a global TB problem of importance in most countries, I would say. There's a quarter of the world's population which is estimated to be infected. Most of these people will be well, about 10 million of them fall sick every year, and about 1.4 million die. And we have about 900,000 of these TB cases which emerge every year associated with human immunodeficiency virus, and another 500,000 who are multi-drug resistant or rifampicin resistant. And I mentioned in distinction these two subgroups because they present formidable problems to TB control. The current horizon for global strategy setting has been defined by the anti-TB strategy, which WHO launched in 2015 for the 20 years after, and it has as a vision a world free of TB with zero TB deaths, TB disease, and zero TB suffering. And the end objective is to finish with, sorry, I need to move a bit. Sorry, can you see now or?
Yes, we can see.
You can see it on the big screen. Yeah.
Yes.
So you can see it scrolling now. Okay, sorry. So the end objective is to remove the global epidemic and bring it down, as you see in this 20-year curve in the blue line, bringing it down to the level that we have in rich countries today. So we are now 1/4 of the way down in the timeline, if you want, and this first 10 years is supposed to be characterized by improved absorption and rollout of tools that are currently available, and we hope that by 2025 we will be able to depend upon more sort of novel tools that we can use to diagnose, to treat, to prevent, to vaccinate maybe people ahead of getting disease. So I think the notion that, that we need to do better with what we have, especially in the first sort of half of the NTB strategy timeline, is very critical to guideline production, because the guidelines are important for us to lead kind of and countries where they have the highest burden, which are usually the countries with the least resources, in order to allocate their investments and their efforts in the right places. And the overall sort of mission of WHO guidelines is really to guide when there is uncertainty, when there is a demand for critical clinical and public health areas such as TB, and especially to guide them when there are new developments, right? Like a new public health problem, and COVID, of course, is one critical example. But also when new evidence comes out, new trials are published, and also when there are changes in the availability of access to services. So very often, for instance, we get a global sort of stock out of a particular drug, and we need to advise countries on what to do. Over the last 10 years or more now, the Global TB Program has been using the WHO recommended process to produce evidence-based guidelines with a very systematic way of selecting the expert panels, which will advise WHO on the recommendations to make, and using GRADE to summarize the evidence, to document the decisions taken, and then produce statements on the strength of the recommendation and the certainty of the evidence that underpin them, and also to translate the evidence into recommendations. So this is the topic of the presentation with the rest of my slides over here. And we feel it's important and has helped a lot to answer many questions that we have when you have a direct link between the recommendations and how they were made, so that the whole narrative is easily accessible to people who need it. And the users of our guidelines are very different. We have national TV programs and other technical agencies and decision makers in the countries that need to make these decisions. But we also have academics who use them, who want to get informed about the research gaps, about kind of what has been done before, and building upon the systematic reviews that have already been done. I think one of the critical elements that has helped standardize our guidelines has been the adoption of this method, and the PICO question, I think, is central to all this. So I think many of the people on the call would be aware of this, but just to make sure, this is when you break down a research question that is used to scout for evidence into these four main components of population, intervention, comparator, and outcome. So this is one of the recent PICOs as an example here that we have used recently. And you can see that, for instance, the population would be the people who are at risk of active TB, who are infected but not yet diseased. In these patients, will this particular regimen of a 1-month daily rifampicin with isoniazid safely, which is the intervention in blue, safely lower the risk of progression to TB as the outcome, compared to another standard of care, or no TB preventive treatment at all. So this is the sort of PICO backbone that has characterized now and has sort of guided the development of the recommendations in the last decade. Nonetheless, we do have challenges in TB guidelines, and here I try to group them under these 4 headings. So standardization is one, because the style of the presentation of our documents differs. There are individual styles of groups, expert panels, and methodologies that influence a little the content and the way that the recommendation is formulated. The terminology has changed over time. Sometimes you have guidelines that are very thick and with a very broad scope. Others are really very, very narrow in scope, because they have come out triggered by, let's say, the release of a particular diagnostic technology or new treatment. Secondly is the updates. So the lifetime of the guidelines differs. Usually we keep it at a max of about 4 or 5 years. and sometimes even that is too long, and we have rapid developments in certain areas which necessitate updates. And then there is the issue about withdrawal of print or online documents, which is always problematic, and the user gets a bit confused if they have an older version of the same document. So it has become a bit easier when you have online documents, of course, but even with that, sometimes definitive withdrawal of a document from online sources has become more difficult. Sometimes you get mirror sites that copy the PDF and all of this. I'm sure that a number of you have met these issues. Also, the evidence, the transparency, and the kind of the trail down to the evidence has not always been easy to establish. Particularly, we had this issue now when we are preparing the maps, because some of the older guidelines to find the original text, sometimes they were in annexes of other documents, and it was not always easy to reach and find the individual document. And a bit like the registry, we try to link these to the original online documents so as to avoid having to create like dependencies or files which have been excerpted from another document, etc., and thus keep the repository linked to the original online texts. And also the other issue about dissemination. So the mailing of paper documents is being wound down now, I would say, for many of our TB guidelines and also TB documents. So we're moving towards more into apps and having everything online, making translations much easier. Also, the issue about fragmentation of different documents has been more difficult in the past, and we are trying to approach this by a process of consolidation. You see over here the first of a series of consolidated TB guidelines. This is the first one that came out last March. On the left, you see the guidelines themselves that form part of a series. This is from what's called Module 1, which is about prevention. Module 2 will be about screening, etc. And on the right, I think something that I heard just now about the implementation aids. So guidelines are the sort of document which come out kind of aligned to what is in the evidence decision frameworks, and which is a basic tool that we use to document the processes. And the handbook is more of a how-to guide about how to go about implementing, let's say, a given regimen. What are the doses that you need to use? How do you do a skin test and things like that? So these are more sort of practice-based implementation guides that and aids that help to the absorption of the appropriate uptake of the guidelines themselves. Coming to the exercise of the mapping, so we had some interviews with the help of staff from McMaster University and some of our staff to poll about what were their proposed enhancements to the whole process, and standardization and automation were keywords that were often used, and there was a demand for a centrally accessible database of recommendations that are currently valid, so that if people go to one place, they will only find the recommendations that are up to date, and they don't need to go back and check whether this document has been superseded by another. So a recommendation map is being built now, and this was devised to address these demands and to provide a linkage to the whole evidence that underpins it. There were a total of about 228 recommendations linked to over 100 guideline questions that were contained in 18 WHO TB guidelines, and these were eligible for the mapping exercise. Some of them, even since we started doing this, have been superseded because we had updates in earlier this year. So this is another notion of what is living in the guidelines, basically, that they constantly in flux, and they need to be brought up to kind of up to date regularly, to make sure that people who are using them are fully informed of what's latest. So key guideline components were database. We will see a picture of this later. and also they are available via a searchable online platform, which is on this website over here, and which serves as the front end for the user. And also this exercise stressed further about the evolution over time in style and articulation recommendations. I think these are lessons which are helpful moving forward now, so that prospectively we try to address some of these issues and make the languages a bit more standardized and the presentation of the results more standardized. So this is the front end of the database. You can access it via the site, and if you click on any of these, these are the recommendations that are organized here in rows, and you have tabs, different tabs. I'm not online right now, so but if you click on any of these tabs, you will be immediately selection. There's a selection of recommendations in that area, so be it infection control or TB prevention, TB preventive treatment, etc. And then if you click on any of these gray lines of text here, which is the actual top line recommendation, you will get to an information page. There's a summary, there's a sort of a place where there is a statement about the strength of the recommendation, about the certainty in the evidence or the quality of the evidence, and then some more details about the population, the age, the intervention, etc. And then eventually links to the evidence summary and to the evidence decision frameworks. And then also some other information down here about the source guidelines with links and some remarks relating to the recommendation itself. And we have been using more and more Grade Pro to document our recommendations and the evidence summaries. This is the evidence summary, as well as the evidence to decision frameworks. And we are now, I think, for the evidence mapping, the interest would be to have the recommendations linked to a site where you can find actually the Grade Pro table rather than going to a PDF. I think this will be an important leap that we will make, but it can only be done prospectively because there's a number of not all the evidence decision tables that we have been finalized in the Grade Pro platform, and therefore it's not easy to link up directly to this, but it will happen. And another functionality of the site is this cross-tabulation with heat maps. So what you see over here on the left are some of the keywords that you find. So you could have tuberculosis, for instance, or healthcare facility, and other forms and other terms such as active TB. And in the columns, you will have the different tabs that you can have for infection control, etc. And you can see mapped here with numbers, the number of recommendations that fall in each of these categories. So you see some of them are missing, and that could be explained because it may not be a plausible sort of cross-tabulation, but some of them you'll see that there is quite a lot of recommendations that show up, and this could be explained, of course, because this would be the area which is most relevant to a particular keyword, right? And a particular category of patients, for instance, or category of users. But also it might give you some sense about where research gaps, and this is where we want to have it focused in the future, where the research gaps lie. And some of those missing sort of spaces do actually represent lack of evidence. And finally, what I wanted to say is that all of the work that we are doing in this database fits into this bigger picture. So you see here the database on the left, which is the repository itself. So the idea would be that this would be an important sort of data knowledge base in order for moving countries towards this development process, whereby countries can use this as a resource to inform the recommendations that they need to adapt locally or adopt without any change. Sorry. Without any necessary changes. Okay, so this would be very important, because especially if there are links to an editable evidence decision table, because with that they could really document their changes using this special development module in the Grade Pro, and eventually implementation and the use of implementation aids. So we have not gone into databasing the implementation advice. Okay, so we have stuck to the evidence-based recommendations as they are devised. So things like, for instance, drug dosages, etc., they would not be able to find them on the recommendations map, because usually those are defined by other processes than the GRADE process we used with systematic reviews. So in conclusion, I would say the consolidation of global policy is very important to help countries move towards the ends of the NTB strategy itself, and using as much as possible an evidence-based approach. And GRADE has allowed the global TB program. Sorry, I think there's some timing that I forgot to remove here. Oops. Okay. Right. So GRADE has allowed the global TB program to standardize guideline design and content, and to present the evidence and decisions more systematically and transparently, and the recommendation mapping facilitates user access to an online repository of guidance. And I think more and more interactive features would increase the use of this tool, and maybe generate more ideas about how these tools could be used and give more sort of benefit. And with that, I want to thank the organizers once more for inviting WHO to give this presentation, our colleagues at McMaster University, Holger, Anissa, and Tamara, and others, Evidence Prime team who have developed the system, Bart and Arthur. Okay, so I need to remove the, okay. So other stuff in our Global TB program, other WHO departments, like the Guideline Review Committee and the Quality and Norms and Standards, National TB programs, technical and funding partners, and patients and their communities. Thank you very much.
Thank you very much, Dennis. It was a very important presentation regarding the mapping recommendations. I think you are one of the pioneers within this field, which is very important, you know, in all kind of now in COVID-19, but in all pandemic stuff and in other examples as well, as you showed on TV. Before we will go to QA, I see there is already submitted a few questions. We will close the pool now. I see that 83% voted. In total numbers, it's 101 persons. And to our question, shall we have one universal guideline registry? 76% of all of you thinks that yes. No, there is just one person who thinks no, and 23 of you are unsure. And I've seen that there were quite discussion regarding this in the chat. So we will go back to this discussion in the general to clarify why 23% are unsure. So maybe we will then reduce this number. So thank you for all who are pulling. And now back to Dennis. Dennis, there is already one question from Ilse Vertinien, who is asking, what does the coloring mean in the cross tabulation? So maybe you can go back within your slides and show it and explain to Ilse.
And can you see my slide or no? No.
You can go back and we will see perhaps. No.
Not yet.
Okay.
Let me go. Yeah. Okay.
Yeah,
Can you see it now? Okay.
Yes. Excellent.
Yeah. So this is just a heat mapping. It goes from like one which is light green, as you see, to red, which goes. So you have the map up here. You see it on the. I don't know if you see the cursor, but up here at 2 o'clock, you see this legend going from 1 to 22 with a color spectrum. And it just means that it's similar to the number, basically. It's, you know, the number is just showing you numerically how many recommendations lie in that space. But the color is another way of expressing the same.
Okay, very good. Thank you. Ilse replied, it's clear, so she thanks. Another question would be from me, Dennis. Well, for the recommendations map, when you have several recommendations from several guidelines, what is your methodology for divergent recommendations? How do you cope with these issues?
Right. So yes. So I don't think I have it in my presentation here. But what we usually do is to pull up all the evidence that exists for both positions, right? And we consult our guideline development group and decide about kind of take the advice of the guideline development group on the way forward. So it could be, for instance, we had few years ago, let's say, a trial which showed very similar findings to the standard of care, but it was non-inferior to the standard, and that was part of the protocol-defined kind of parameter for the trial. So there was discussion about the significance of applying a trial, a sort of protocol-defined non-inferiority when it was compared to something which could be modified, and how that could be sort of how would I say, how could be used. And I think it works out mostly in the way the recommendation can be implemented under different settings. There's probably some of those elements are very important to ensure the proper or a very close sort of reproduction of the trial findings under programmatic conditions. So that could be one, for instance, one situation where we had to seek the advice of GDGs. And similarly, let's say if we have trials that show one diagnostic performing, for instance, and another trial showing that doesn't perform, or that you'll have. So we need to look carefully at the quality of the evidence, grade it. So maybe if you see, for people who are not familiar maybe with this table, so there are a number of domains over here where you can strike down, let's say, the quality of the evidence and bring it down. So we do an assessment of this nature, and depending on, let's say, whether you have 5 trials that have shown the same thing more or less, and one trial that's showing something completely different, we try to assess them in that sense, using this table, using forest plots and other tools to illustrate the facts, and then decide between the group on the basis of the evidence and also the implementation implications, what course of action to take. And it could be worked out in the wording of the recommendations, right, on the direction, the strength of the recommendation, the conditionalities that could be put in, or also sometimes we issue no recommendation because there is important uncertainty, or else if there is interest to do the intervention, but only under certain controlled conditions like operation research conditions. So that has also been one of the way to move this forward.
Yeah, thank you, Dennis. And here is a comment and question from Jonathan Sussman, who's saying that this is really interesting work and asking you if there are any plans for the frameworks for the evaluation. For the evaluation, well, this is quite fresh. So we launched it in March, partially. So, but we want to have. We are in the process actually with the McMaster group to do an assessment already of what people's preferences are when you map these the recommendations in this way. So I think we're providing them with the website basically and telling them what would you change on this interface, what would you like to see differently done, organized differently, etc. So a few, not a lot of questions, but just to keep it kind of manageable and answerable by busy people. But it will be a first sort of try to see if we're on the right track in terms of sort of the layout and the structure of it. And yeah, I mean, we will certainly want to keep it active and relevant for our users. So we will keep tracking it and evaluating it into the future. Okay, excellent. Thank you very much, Dennis, again. And I am giving word back to my dear fellow moderator, Markus. So Markus will introduce next speaker.
Yeah, thank you. So I'm very happy to introduce the next speaker, which is Tamara Kredo from Cochrane, South Africa. And excuse me. Tamara is a medical doctor with a specialist qualification in clinical pharmacology and PhD in public health. And she works in the field of evidence-informed healthcare, in particular evidence synthesis and knowledge translation. Her research includes exploring the South African primary care guideline landscape and developing partnerships for enhancing guideline activities in South Africa. Additional fields of interest include enhancing regional clinical trial transparency through the Pan-Africa Clinical Trials Registry and supporting learning initiatives for evidence-informed decision-making in South Africa and the African region through her affiliation with Stellenbosch University and work of the Cochrane collaboration. So the screen is yours, Tamara.
Thank you, Markus. Thank you for that introduction, and thank you also for the, yeah, let me find my slides, and then I will speak with some, let's see, sorry, one moment. Okay, I think I found it. Are you seeing my slides? Because I'm not. Hang on one moment. Okay.
You see, we were sharing something, Tamara, but it was not the right slide.
Okay, here we go. So, apologies, colleagues. I think I don't have an excuse like Zach that it's the middle of the night. So let's see if this works. And please let me know if you're seeing, are you seeing the main?
Yeah, perfect.
Not presenter view. Okay, excellent. Well, then now I can carry on with my greetings. So hello, everyone. It's great to be on the session with you and amongst these amazing speakers. And thanks to the scientific committee, to Holger, Miloslav, and others for inviting me to talk. I am going to be speaking about the COVID-19 living recommendation map and the gateway to contextualization. And just to say that I'm talking on behalf of the project team. So I'm standing on the shoulders of friendly giants. And I'm delighted that Holger Schinnemann and Tamara Lotfi and others from the team are on the call. So I'm presenting on behalf of us all. And this is a very exciting project to be part of, both as someone who is involved from the as a co-PI in the kind of methodological discussions around how this project is playing out and how this COVID map is developing, but also as someone who works in a setting where we don't have all the resources necessary to mobilize massive review teams and guideline panels to develop our own guidelines in this COVID context. And so I'm hoping to also be a user of the outputs of the products of this project, which I'll present to you now. So colleagues, let me tell you a bit about this exciting project. I must first just put up my declaration. So although there are no direct conflicts with the content that I'm presenting, here are some of my affiliations, and of course, importantly, an acknowledgement to the funder, the CIHR, and the collaboration between the Norwegian Institute of Public Health and Cochrane, Canada. So I think this conversation about duplication of efforts and research waste has been going on for a long time now, but really COVID has really shone a spotlight on the volume of duplication happening. And it may sound a little bit dramatic, but it actually breaks my heart sometimes because we have such limited resources, and then I see these amazing teams kicking into action and actually all doing the same reviews on similar topics. And I just feel like that I think really the crux of a lot of the discussions happening in these webinars has been about how do we collaborate better, how do we draw in the resources, and actually, there have been some incredible examples of international collaborations, but what are the gaps and what are the things we can improve? So in light of all this duplication of guideline development, and not to mention that, I guess with the duplication of guidelines, it's important to say also that, I mean, it makes a lot of sense that different settings would have different kinds of guidelines, and that would be the result of the different settings and the need to contextualize. And also this speed at which things have been happening in the COVID context and the need for local considerations might mean that guidelines and recommendations are made that are less credible because of the speed and some of the potential shortcuts that are needing to be made. So through all of this, I think quite quickly the team at McMaster and Holger as the PI and others recognize that there's a need for credible recommendations for different target users at the recommendation level, consolidated across all of these guidelines that were coming out. And this was really the background to this project. So the eCOVID-19 Living Recommendations Map, where the main intention is to provide decision makers and other stakeholders, including patient representatives, the public and users, with an easy to navigate, living, freely accessible electronic platform that includes all the published trustworthy COVID-19 recommendations. And that trustworthy is quite an important component of this. And so the project team is working to identify, appraise, and make available all of these recommendations across several guidelines that can then be contextualized and implemented by decision makers. And so I'm really pleased that Dennis has presented before me, because that's really, as Miloslav said, you know, Dennis and the team and the global TB team at WHO are the pioneers in that work. And really that was the basis and the platform for this COVID project to kind of take off. So he's introduced a lot of the concepts that I'll be building on. And this is from an international team, and this is shown here, which makes the work particularly exciting. There are different resources, skills, ideas coming from all these different groups. It does make the kind of team meeting timing quite challenging for some because of the far extremes of involvement, but it is a delightful team to be working with. So the key points and the behind this eCOVID-19 Living Rec Map is free access. It should be living, so regularly updated, including high quality guidelines, user-friendly, and then linked to evidence platforms like Grade Pro, which I'll show shortly. And this provides the gateway for guideline groups like, for example, the group in South Africa to take and contextualize, to either adopt, adapt, into our own space. And it uses multiple integrated web tools. So in order to provide this amazing recommendation map, there are a few steps that need to be followed. So for example, the first would be typical step of finding, appraising, and extracting these guidelines. And so the process is underway where there are these comprehensive searches conducted. So there's an electronic search happening using this McMaster Plus resource where there are 5 guideline websites being searched regularly. There's also hand searching of other websites to make sure that all of the possible relevant guidelines are picked up for COVID. Following the identification, once you've got the guidelines, they need to be appraised. And so the team is using the validated agree to tool, which many of you may be familiar with. But in order to make this a kind of less onerous task and also focusing on the kind of, I would say, non-negotiable domains, the most important domains, the focus is on the 3 domains: scope and purpose, rigor of development, and editorial processes. And scores are then calculated for each domain with the intention of including the higher quality guidelines with at least 60% on each domain. But the consideration has to be given at the moment also to making sure that key guideline organizations are also included along with their agree score, and recognizing that not all are able to score at 60% or above, as we're finding. And I think from the webinar yesterday on rapid guidelines, you'll see that sometimes there are shortcuts necessary in order to produce a guideline in 10 days, which means that some of the information needed for agree assessment are not available. So once you've identified and appraised the guideline, the idea is to extract it into this tool. So just to say, many of you may recognize this GradePro GDT interface, but in fact, this is a customized, separate, linked, but separate version of GradePro where the guideline information is entered. So where was the guideline, who developed the guideline, any citations, etc. And then drilling further down from the overall guideline level into extracting information about the recommendations. So this will collect a number of variables, the PICO information, whether it's treatment and rehab or prevention or diagnosis, what the agree score was, etc., and other qualities linked with this that you could then search for and filter for when you were looking for the recommendation. So just to explain some of the thinking about how a recommendation does get included, the aim is to have at least 3 trustworthy recommendations or up to 3 trustworthy recommendations included in the map. So, and this will be based on the agree score, the completeness of the information in the evidence to decision criteria, and the currency. So when was the last search conducted for this? And these will need to be kept up to date, which is an interesting concept I'll come back to because the team is now available with the funding for the year to keep things up to date and making sure that even if recommendations are kind of, a new one replaces it and you're still holding on to the previous recommendation, that is still accessible and seen within the database. So one of the methodological issues that the team is facing now as they're starting to work with the data, and I guess this wouldn't be a surprise to many who are looking at these COVID guidelines, would be divergent recommendations. So that is recommendations where either the strength, whether it's strong or conditional, or the direction may differ between the different guideline groups, and trying to unpack why they may differ. So there will be a process within the database. There'll be a kind of a grid where you'll be able to see why what the divergence is and what the reason was. Was it a contextual issue? Was it about access? So here we have an example of where ventilation, a colleague has pulled out data, Stephanie from the project team has pulled out data about ventilation from 3 different guidelines with some differences, but there'll be a deeper delving into why they differ, and this will be shown within the database. So once the team has done all of the hard work of finding, appraising, extracting all of the data, the idea is that this must now become a useful tool that can be available to people to use it. So this is exactly what Dennis was demonstrating. So the tool has now been kind of activated to include COVID information, and this is the map or the matrix view, and also the heat map view. So this is starting to be populated. So that's why the numbers are starting to come up, and you can see this version would be just to have an overall view of which recommendations are there under these kind of key intervention headings. But to dig a little bit deeper, similar to Dennis's slide for the TB recommendations, this is the list of COVID-19 recommendations that can then be, you can filter and search for different variables. But further to that, you can kind of click into these recommendations and find out more details about where this recommendation comes from, the strength of the recommendation, some of the PICO elements, and then you can link from here into the evidence to decision profile. So this is one of the important linkages, and which kind of adds to the value and the use and the accessibility, is that by clicking through to this, you'll then be able to access the evidence profile. And as a guideline developer at a national level or somewhere where you want to kind of adapt or adopt or develop a guideline, this means that you'll be able to find evidence profiles in GradePro. So this is an incredibly handy function that the team is working towards. And this supports this gateway to contextualization, taking an available recommendation, understanding what the quality of that guideline is that it comes from, and also the content of the evidence to decision tables, and then doing a process of development. So adopting, adapting to the country's needs. And this will require evidence on that complete the criteria for that people's values, equity, resource utilization, acceptability, feasibility. And so there's this amazing linkages that are happening between available databases that I want to share with you. Just to show the GradePro screen here, that you have the original guideline here, which you could kind of use the same data, or in the development, you might have different research evidence or different considerations to kind of discuss with the panel. So one of the platforms that we link with as one of the key partners in the project is the Norwegian Institute of Public Health Systematic and Living Map of Reviews and Primary Evidence. So this is a great source to be able to populate information about COVID-related values, equity, resource utilization, and other aspects. There'll be a direct link with the e-COVID-19 maps. I don't know if you all know, I love evidence. I mean, I do love evidence, but this particular group love, where they have kind of emanated from the Epistemonicus group, where this is a specific COVID-19 database that hosts, it boasts that it hosts the most systematic reviews on the topic, and it's doing regular and comprehensive searches of multiple databases. So in fact, this is where I go, and I think many people go to look for systematic reviews on this topic. But the interesting thing is that this is where you'll be able to link directly with the rec map to be able to enter information about, again, finding reviews about equity, resource utilization, acceptability. So better utilization of these platforms, but better completing of the evidence to decision frameworks for informing decisions. And of course, as Zach introduced earlier, there's the linkage to the new GIN library. So these are all interlinkages that the databases and functionality that the databases will have. So this then leads to the possibility for countries to take those recommendations and do a development. And so here you have the original recommendation, where you can see all of the different criteria that the original guideline decided on. And then in the development process, you can see where it might be the same as the original, or it might change. So for example, here with physical distance, in the development process, acceptability deviated, and there was a change, and this is all very, very transparently displayed. And this then also can link with the display of the recommendation. So you can see how and why you deviated or were the same as the original recommendation. So just in a nutshell, to talk about some future and the challenges with sustained activities, the same way this GIN webinar is named kind of a pit stop in the marathon of COVID. COVID has indeed become a long haul marathon. The idea that there would be kind of this short-term predictions of having this rec map, making it accessible and getting it into use, it seems that there are now going to be ongoing guidelines for longer than originally anticipated. And therefore collaboration, contributions to this platform is going to enable the sustainability beyond the original planned process. And the other important aspect of this is that dissemination, so sharing, so we're sharing it in a GIN webinar, but in fact to ultimately get this rec map into use, there needs to be very active dissemination, communication, and engagement and support of guideline groups, which will be critical to its use and ultimate impact. And that's also something, as Dennis was speaking about, is that we're at the early stage where there's still the process of having to get this into use, but there's an incredible database that and opportunity for global collaboration. So some reflections and gaps as I wrap up. So I think we've all seen a kind of phenomenal examples of global collaboration on evidence synthesis. So systematic reviews that would traditionally take 2 years, taking 2 weeks, with massive global collaborations. But these were generally reviews of effectiveness. And besides those amazing examples, which hopefully will kind of bear a bit more fruit as there's more collaboration, there are also many examples of duplication globally. But the one gap that remains is the need for the contextual data for the evidence to decision frameworks. And this is still something that's kind of not as front and center. So we look at what works and what doesn't work, but the issues are, what about people, how much people value the outcomes we're interested in? What about feasibility, acceptability? And so this is also a call for the evidence synthesis guideline and the HTA community to better collaborate on evidence synthesis on the contextual factors. So these are some of the reflections and gaps to put forward, and hopefully we can discuss some more on this. So just to acknowledge, firstly, of course, the scientific committee and Jin overall, but also the funder, the vast team, and a special thanks to Holger and Tamara for support with the presentation. So thanks, everyone. Look forward to questions.
Yeah, thank you so much, Tamara, for presenting this really impressive project. And I'm looking for just checking the questions. Well, how are you keeping up with the living record guidelines when it comes to using Agree and then updating your own work based in the updates? What is the general process and time lag for an updated guideline to a change in your recommendations? Tamara, can you hear me?
Ah, sorry, I was muted. Thanks, Amir, for the question. I don't think anyone's keeping up with anything, to be very honest. But I think that the project is at the inception stage and the kind of database build stage. So I'm not sure if Holger or Tamara want to add in anything there, but this is obviously a very important point, is how we make sure we keep up to date, because that is part of the mandate.
Exactly, yeah. This is, I'm really impressed. So we have special situations due to COVID, and definitely very special funding for these works. And yeah, I'm just wondering whether you can transfer this very helpful work for other topics and more broad, which seems difficult.
I think it sounds like a fantastic idea, and very closely linked with the idea of kind of repositories that Zach introduced and the TB work that Dennis is leading. Holger, what are the teams at McMaster? What is the vision beyond COVID, or are we, TB and COVID? What are the discussions happening? I'll hand over to you.
Well, happy to participate. I put something in the chat to answer in Army and in writing in particular, but expansion to other areas. You've seen TB, where this really generated from, and now COVID, expansion to other areas would obviously be possible and probably necessary. With regards to keeping things up to date, we are continuing to monitor new recommendations, and then would update those recommendations that are displayed on the basis of the updates, and on the basis perhaps of what the most trustworthy recommendations are. We would be retiring recommendations, put them in a registry. Yeah, those are probably the quick answers here.
Okay, yeah, thank you. I just checking now, there are no further questions, and I'm very happy for all the discussions we had until now, but I guess we have to forward to the next speaker in order to keep our time schedule.
Okay, thank you very much, Tamara, for excellent and important presentations. I have to say that we are very much looking forward to the first results of this project, as you know, it will informing our national guidelines. So hopefully the first results will be soon. I think it's very important. So now let's move to our next speaker. It's my pleasure to introduce Dr. John Grove. John became the first Director of Quality Assurance for Norms and Standards on July 1st, 2019 at WHO, headquarters in the New Science Division announced in March 2019. He's establishing and leading functions and assurance services for all WHO global norms and standards products, and oversees the WHO Press and WHO Global Library and Digital Information Services. Prior, he was director of the Department of Information, Evidence and Research, overseeing global health statistics, monitoring and evaluation, applied ethics, research coordination and guidelines development. He joined WHO on 1st September 2017. Before joining WHO, Dr. Grove was Deputy Director for Evidence and Policy in the team at the Bill and Melinda Gates Foundation. He was responsible for the investment portfolio on evidence and research, and also worked within the organization to set strategy and guide related health analytics. Prior to Bill and Melinda Gates Foundation, Dr. Grove was with the US Centers for Disease Control and Prevention for 8 years, in team lead and section chief roles based in Tanzania, Zambia, and Côte d'Ivoire, supervising disease surveillance, program monitoring, and evaluation. He has authored several peer-reviewed articles, book chapters, and reviews. John, welcome, and please share your slides with us. Yes, you should be unmuted in a little while.
Great, can you hear me?
Yes, we can hear you.
And can you see the slides?
Yeah, we see the slides.
Okay, great. Okay, is it up now?
They are up, however, we see them not in a presentation mode, but you know, in the other mode. So maybe use more screens. So you can try to switch to presentation mode. Or you can stop sharing and share the screen where your presentation appears. I assume you are using more monitors than one. So this is perhaps why we don't see it in a full presentation mode.
How about now? Is that better?
No.
It's worse.
It's a little bit worse, but I think you will make it.
Can you see the screen at all?
We see the screen. However, we seen you know, the slides, the view of presenter.
Okay. How is that?
Yes, now it's perfect.
Okay, good. Sorry about that. Well, hi everyone, and thanks so much, Markus and Miloslav, for coordinating this session, and also thanks to Holger for the invitation. And I'm also representing a team of people. I think many of them are actually on the call today, our methods and standards colleagues. I joined the WHO in 2017 and had the opportunity to work also with Dr. Susan Norris, who I think has been quite involved in the GIN group as well, and learned a lot from her. And at the same time found her to be one of the few people working across the house here at WHO on guidelines and norms and standard products. So we made some recent decisions to really build out this function much further. And so I'll talk about that today. And my
my only thing to declare is I work every day as an international civil servant, and we hope to provide as much good to the public as we possibly can, and really thank all of the partners on the call here who we work with either individually or also with Jen as a group. And so what I want to talk about today is looking at kind of the genesis of our new group that we formed here at WHO, building on some other pieces of the organization that we're pulling together. I'll talk about how we're applying quality assurance, some of the things we're putting in place to ensure better planning, some of our methods work that we're continuing to advance, and then get into a bit more around how we're handling recommendations and also the COVID-19 response. And I really do think of this as, you know, there was already a lot of urgency around getting more information out on guidance and policy, but the COVID situation has only accelerated that even more. And in some ways, it's given us a real boost to look at some of the things we always wanted to do to speed this up, but given much more urgency given the current situation. And so I'll touch on that as we go forward. I'm just trying to do the change of slide here, which has a bit of a delay.
Yeah, John, something happened, and we don't see the slides well.
Mm. Seems that Zoom is not enjoying this at the moment.
Yeah, you can maybe try to stop sharing now and try to share it again on the screen where your presentation appears.
And if that doesn't work, I'll just give a talk about that. So we save time.
Yeah, it's not better now. So I can try to share your slides.
Okay.
Just give me a second.
Maybe this is a good time to launch the next polling question while we are doing this. Or Miloslav, I can share John's slides as well if you want me to.
Okay, excellent. So maybe you can do it because John sent me only PDF. I don't have the PPT version, so you can perhaps do both.
And John, you could just, if you're seeing my screen, you can just tell me when not to click next slide.
Okay, great. Thanks, Holger. Appreciate that. I'm not sure what happened. Yeah, so just to give you a bit of background, in 2017, we had an evaluation of the norms and standards function at WHO, and it made some very specific recommendations in terms of improving our ability to produce guidance and policies. And I think it was great to see Dennis's presentation because he gives you a view from the department perspective. And we're learning a lot from the TB program in terms of how they've been able to organize and manage these processes. And at the same time, that same coherence hasn't been there at the organizational level. We've made really quite some advancements on the Guidelines Review Committee. We've never really had enough support in terms of people, as Susan Norris will tell you, to shepherd these processes at a high level. And so we have an exciting opportunity on the heels of our 2019 transformation and reorganization, where we're prioritizing the products that we're producing or our global goods. We are putting in place fit for purpose quality assurance processes, mechanisms, and also hiring staff to help support those processes across the house. And finally, creating this department, QNS, to own that end-to-end process. And we're talking about guidelines, but also other norms and standard products, such as how-to manuals, strategies and roadmaps, implementation guides, etc. We also then have within our group the publishing function and the library function as well. So it's the whole end-to-end of the method support, the product management, the impact design, as well as the library and press. We also manage the collaborating centers accreditation, as well as the technical advisory groups and expert committees from our group. So it all fits together now under one roof. So if we go to the next slide, it's a bit more about the mission and the functions, which I've just described, but we really see it as an impact cycle where prioritization is done. We're putting as much equal weight into the activities around the scientific process and trying to put more and more attention also on implementation, adaptation, and monitoring at country level. So if we go to the next one, it's like Holger may have lost the screen as well. Holger, I'm just wondering if you're still there.
Okay, seems that we lost.
I'm here. Sorry, I was trying to make it look better. I apologize for that.
Okay.
You should see now.
All right, thank you. So we can keep moving, I think. Go ahead to the next one. And so when we talk about norms and standard products, we talk about anything that is an information product that tells people what to do and how to do it. We also have standard setting products where we indicate labels or thresholds, continuous measures, and different kinds of assessments. So we're taking a broad view. So guidelines are part of that picture, but not all of it. We go to the next one. One thing that we're also doing across the organization is putting forward a set of principles where we can look at quality aspects of all of the norms and standard products, including the robustness of the process, the comprehensive steps being followed, the suitability of the methods being used, transparency, reporting, and presentation, and really pushing for teams to think more upfront about the optimization for use and impact at country level, and then the plan for that monitoring and follow-up. Next slide. We are working to front load more planning of all of the policy guidance, norms, and standard products coming out, where we have introduced a planning approach that really asks for a lot of those things that would be potential pitfalls when you get later into these processes. So information about the product, the overview, and asking first about the target audience and first about the desired impact and scope, even before getting into some of the scientific questions. We're also pushing for clearer delineation of who all the contributors would be, and then the actual approach to the decision-making process and the formulation of the guidance with various factors. For us, we need really a balance of gender, looking at equity and human rights issues, also ensuring that we have regional representation for the development of global guidance. Next, please. The other pieces also really urge teams to think early about the writing, editing, and publishing. We don't see enough translation. Translation has a cost, so we're trying to get our teams to consider that much earlier on. Better definition of what the derivative products would be, the monitoring and evaluation plan, and of course all of the project management, and then a plan for also updating. How soon do we think we might need to be updating these recommendations? What's the plan for using an approach that would enable that, such as a living guidance approach? Next, please. As Dennis noted, our best practices are rooted in our famous handbook for guideline development, where we put forward the 4 areas of relevance, compliance with ethics and human rights standards, highest quality, best available assessment of risk and bias, the publicly available data and information, and the transparency in the methods used and who's engaged in that process. And as we move forward, we're building new chapters and new tools, both for teams and for collaborators, into the handbook on a few new areas of concern. Next slide, please. You're all familiar with GRADE and GRADE Decide frameworks. We're also looking to implement the Integrate framework as well, where we're building on the strengths of GRADE and adding in the health equity issues, human rights, societal impact, and health system considerations, much to the points made earlier around the need to get a real handle on contextual issues and implementation issues. Next, please. One area that we get a lot of questions, and I think would be relevant to also a discussion on registries and such, is around what do we do with guidance that's produced by other organizations other than WHO. And so we deal with this really every day, because we can't assume that WHO is producing all of the guidance for everything under the sun. And there are also great capacities in other places. We also deal with national authorities as well, which have their own systems and processes. But at the end of the day, what we're looking at is really the relevance or applicability. You know, does the guideline and the recommendation address the key areas of uncertainty where our member states need guidance? And again, we're always looking at the ability to produce a global set of recommendations. We also need to look closely at, of course, the conflicts of interests and the funding sources being assessed, the listing of the contributors and their affiliations, and also the systematic review of benefits and harms of the intervention to inform those recommendations. So as you can imagine, we often will get proposals from academic groups or other partners that have developed something very, very useful, but it hasn't necessarily gone through the global relevance test. It maybe doesn't share all of the different contributions to that process. It maybe didn't include a diverse array of stakeholders in its development. So these are all things we, as a UN specialized agency providing global guidance, need to pay attention to. But we're happy to discuss this with people, and we don't want to create barriers or gates, and we also don't want to limit the world of getting useful information. So we're trying to figure out ways to do this, walk this line a little bit more constructively, I think, into the future, and tagging really what is official WHO guidance versus what are we acknowledging or recognizing as other useful products. So we're open to ideas on that as well. Go to the next slide, Holger. This is work that Susan had started also with Dr. Evelyn Whitlock, where we're looking at trying to systematize the harvesting, essentially, the gaps in evidence to inform our research cycle. Within the science division, we have another department called the Research for Health department. They've just come through with the research prioritization framework and strategy, which is on our IRIS database. And part of that plan is to link with us to bring the identification of evidence gaps from the guideline development process more into the forward-looking research strategy setting. And I think this is going to become, certainly for COVID, a very, very important cycle. So we've got team members starting to look at how to bring this framework into action. Next. For COVID-19 response, as you can imagine, it's been an avalanche of activity, and some of the craziest period of many of our, I think, our professional lives, and certainly here at WHO, where we've been working very closely with our emergencies team. We have an integrated response team that is kicked into gear whenever there's a public health emergency of international concern. And so we've learned lessons from previous rounds with these big emergencies and put in place a few things to get things out much faster. So we've put together a centralized publication and prioritization committee that does the quality assurance on proposed mostly interim guidance within a 24 to 48 hour turnaround on those products. This is a committee that's headquarters and regional staff. They've looked at over 600 different items, done a lot of harmonization, and put out about 200 plus publications on this. Our IRIS system is receiving huge amounts of downloads every month. Usually it's around 2 million downloads. We're up to anywhere between 4 to 9 million downloads. And then we've also got a new WHO 19 literature database with some 100,000 citations, and we're also coordinating a rapid review team. Next, please. We're looking at ways to improve our processes and systems, so we've introduced a new best-in-class publishing system. We are leveraging what's happening in TB and also working with some other teams also for COVID using a living guidelines approach, so working with both GradePro and with Magic, and looking at how to pivot more toward a design process that gets us quicker to something digital to deliver rather than paper and PDF. Next, please. We're working on a design and implementation package as well, which will keep going. Holger will finish here. So moving forward, we'll be looking at expanding our support and approaches and methods. Also a big focus on design, project management and development support, and all with an eye towards reach and impact. The other thing I wanted to let you all know is we do have evidence for COVID collaborative that we launched in March. We have about 100 partners in that group and working closely with COVID and Cochrane, where WHO shares its priorities for reviews. We also hear from other partners what they're doing and have created a centralized website for that, which I'll put in the chat. I will end there. And sorry for the technical issues. I'm not sure what happened, but thanks.
Thank you very much, John. Thank you for a very interesting overview for what the WHO is doing. We've got very rich discussions in the parallel section as well and some technical issues. So we have 5 last minutes to go. So there will be space for 2 quick clarifying questions to John, and then we'll go to the pool. So any questions to John for what he presented? I don't see any yet, so we can give you more space. So Holger, please, can you close the poll? And we can see the results. So the results are here. So the next question was, should the guideline registry include also evaluation of reporting and methodology? And 74% of you thinks yes, 6% no, and 20% are unsure about this. So I think this is quite good. This is quite good result and feedback to Jin for the register. And we have a question from Holger Schunemann to John. John, I will unmute you. So do you have a framework for research priority setting resulting from guideline recommendations in place, John?
So at the moment, we don't. The slide I showed earlier, we've done the exploratory work on that. But part of the task is moving from the framework to actual action. So I wouldn't say we're there yet in a systematic way, but working on that, yes. Okay,
very good. Thank you very much, John. As our time is coming, I will switch back here. So thank you very much all. Thank to all participants for very rich discussion. And here we have few closure slides here. So the GIN COVID-19 resources is where you can find the guidelines regarding the COVID-19 within the GIN library. It is a page which is updated regularly and provides informative links and useful information on the current outbreak. There is a new partnership with McMaster University, engine on guideline development, credentialing and certification, the InGuide program, which is a program for guideline panelists, methodologists, etc. It's very interesting, so you are very welcome to register. And all on behalf of the GIN and the Scientific Committee 2020, thank you very much for attending this webinar today. We would very appreciate your feedback and invite you to take part in our post-webinar evaluation. And also let me to invite you for tomorrow last session, the fourth session, which I believe will be also very interesting. And now I'm giving word back to Markus, who will send the last words of today's excellent session. So thank you very much to all speakers and presenters from me.
Thank you, Miloslav. And to make it short, a huge thank you to the presentations and the engagement and to the fruitful discussion. And I think it is a perfect starting point for further discussions. Thank you so much.
Thank you. Bye-bye.
Markus, Miloslav, okay for me to end the session?
Yes.
Thank you.
Okay, bye-bye everyone. See you tomorrow.
Bye-bye. See you.